Okay, so let me know when I should begin discussing. Welcome everyone. It's great to be here with you today. I'm Dr. Joseph Vassilotti. I'm a nephrologist or kidney doctor. I am the National Kidney Foundation's Chief Medical Officer, and I practice nephrology at Icahn School of Medicine at Mount Sinai here in Manhattan. We're here to take your questions, and we're focusing on pain today. And the reason we're interested in having this conversation with you is that for many years the National Kidney Foundation has been advising patients to avoid non-steroidal anti-inflammatory drugs or limit their use. And we're concerned that that could result inadvertently in patients taking more opiates. So we wanted to discuss pain management in chronic kidney disease, and we look forward to taking your questions. I'm going to frame the discussion with you a little bit just to get us started and hopefully to help you think about the questions you might have and to send them to us. So first, why is pain important? Well, obviously pain affects your quality of life. It's associated with sleep problems, insomnia. It's also associated with depression, and it may limit your ability to participate in school, work, or family and social life. Pain is common in people with chronic kidney disease and in those treated with dialysis. About half of patients treated with dialysis and with advanced kidney disease report pain. Pain may also be associated with the dialysis procedure itself, particularly hemodialysis, where pain can be associated with the cannulation or the insertion of the needles in the graft or the fistula. And the dialysis session itself can be complicated by cramps or headache. It's very important to talk to your clinician about the pain. This conversation we're having is to stimulate your interactions with your clinicians and not a substitute for your clinician's care. Clinicians usually start with the severity of the pain, and generally a numeric scale is used where 0 is no pain and 10 is the worst pain you could imagine, and then in between is reporting the level of pain that you're having. Doctors typically separate pain in terms of nociceptive or tissue damage pain, and neuropathic or nerve pain, and headache pain. So these are 3 different types of pain that are very common in kidney patients. Tissue damage pain could be from arthritis, gout or osteoarthritis, wear and tear arthritis. Neuropathic pain or nerve pain often occurs with diabetes and as part of kidney failure or uremia itself. To help your clinician understand the pain, describe it. Is it aching or pressure-like in nature, which usually is associated with headaches or the tissue damage type of pain? Or is your pain tingling, burning, or an electric-like pain, which is more often seen with nerve pain? Tell your clinician what makes the pain better and what makes it worse. Where do you have the pain? Is it in your knee? If you have arthritis pain, is neuropathic pain, you might have a stocking glove-like pain in your leg. What time of day do you get the pain? And then in general, when we go to treatment of pain, the World Health Organization recommends a 3-step approach to managing pain. Mild pain is usually treated with drugs like acetaminophen or Tylenol, which is available over the counter, and the non-steroidal anti-inflammatory drugs, which are also available over the counter. So what are these non-steroidal anti-inflammatory drugs? They're painkillers that are available by both prescription and over the counter. And why we focused on limiting the use of these for so many years is that patients may believe that anything offered over the counter must be safe. But unfortunately, these drugs, especially when used for a prolonged amount of time, have been associated with acute kidney injury or sudden loss of kidney function, chronic kidney disease, or prolonged loss of kidney function more than 3 months in duration, as well as progression of chronic kidney disease or lowering of the kidney function worse than it was before. These drugs have also been associated with heart failure and hypertension, exacerbation or worsening of blood pressure control for people who have high blood pressure. And lastly, there are other side effects of NSAIDs like gastrointestinal upset or GI bleeding. Before other drugs like opiates are considered, alternatives to drug therapy should be offered, and in general, moderate to severe pain should only be treated with opiate agents. The World Health Organization represents this three-step approach to treating pain, and in general, we want to ensure that there is a plan for limiting the side effects of these agents and also limiting the risk of addiction. The side effects that are important for opiates include nausea and vomiting, and especially constipation, and then sedation or confusion. So there should be a plan to balance the side effects with the risks of addiction. So we look forward to taking your questions. I've just given you a brief overview of pain and chronic kidney disease and advanced kidney disease in patients with kidney failure treated with dialysis. Some of the drug options, including the non-steroidal anti-inflammatory drugs, acetaminophen, and opiates. And with that, I look forward to hearing your questions.
Okay, Dr. V. One of the first questions that came through from Sarah was about migraines and transplant. She wanted to know if that's common in the transplant patient.
Yeah, okay, thank you for asking the question. So the question is about migraines and transplant. Certainly, in my at least personal experience, I've seen patients who have those two conditions, kidney transplant with migraine headaches. I don't know the data about whether or not that's more frequent than in the general population, but certainly that's a concern. And certainly if you have a kidney transplant and you're having migraine headaches, you should work with your transplant team and headache management team to control that. And of course, you want to consider the interaction of any treatment that you take for the migraine headache with your immunosuppressive therapy for the kidney transplant.
Okay, and that segues very nicely into the next question from Rosemarie, who was asking about the use of medical marijuana in transplant patients. So I think that that's very much related. So you can address that.
So I think medical marijuana in kidney transplant patients is difficult for me to talk about publicly here, because I think I would direct you to your transplant team, and I've heard different things from different transplant teams about their approach to that, both before the patient's a candidate for a kidney transplant and after they have a kidney transplant. So I think that you would be best served by working with your local transplant team to have an answer to that. There are concerns about the immunosuppressive therapy and the exposure to marijuana, so you would want to make sure that it was medical marijuana and not other types of marijuana that might be available that might promote infections. And I certainly have read case reports of unusual infections that occurred from marijuana that was tainted with infectious agents. And we could talk about medical marijuana and CKD perhaps subsequently.
Very good. We have another question coming in from Midge, who wants to know if arthritis medication is bad for your kidneys. I think you already touched upon that, but if you could just give a little more information for her.
Okay, so arthritis medication, I'm not sure what that means. So of course it could be acetaminophen, Tylenol, it could be non-steroidal anti-inflammatory drugs. There are some drugs that are used for gout that we can consider arthritis medications, which may be completely safe for the kidney. Tylenol or acetaminophen is generally safe for the kidney, so certainly those drugs would be safe for the kidney. As far as the non-steroidal anti-inflammatory drugs go, depending on your kidney function, if it's very low, it may be difficult to take any or a very short course of non-steroidal anti-inflammatory drug may be something you could do, partnering with your clinician. If you have a higher level of kidney function, then a lower dose of a low dose of oral non-steroidal anti-inflammatory drugs might be something you could consider. And then I think there are topical non-steroidal anti-inflammatory drugs that are available. So these are available as creams that can be applied. They work very well on knees and fingers because it's a little bit messy for other joints, but certainly for knee osteoarthritis or finger osteoarthritis, the topical agents may help. And then there are over-the-counter agents that sometimes work. There is the salicylate or aspirin-like Bengay over-the-counter that kind of tricks the nerves into thinking that where the pain is coming from. That may be helpful for some patients. Some patients may say they have relief from that. But for all these treatments, you should work with your clinician to decide what's best and safest for you.
Okay, great. We have another question from Tony, who has fibromyalgia, and she just had her transplant in April. She says she has a injury from surgery and severe pain in her left groin and numbness in her leg. They just cut back on her opioids, but she still needs relief. So do you have any suggestions for her?
Okay, so this may have come up, or maybe will come up with other questions, but I think, of course, work with your clinicians to try to limit your opiate use. Consider the use of other adjuvant treatments, so you could try Tylenol in addition to the opiates or other agents in addition to the opiates with the guidance of your transplant team. And then I would focus on some of the non-drug therapies too that might be helpful. Physical activity, heat and cold probably is not something you want to use for this type of problem you're having. I would also think that psychosocial intervention might help you. There's cognitive behavioral therapy that you can discuss with your clinical team that may be helpful as an adjunctive therapy. So these are therapies that may add relief to what you already are experiencing to try to limit your exposure, or maybe even ideally eliminate your use of the opiates.
Okay, now we have another question from Srinivas, who says that he underwent a transplant a year ago and he has bone pain and wants to know what to do about that. I mean, we don't know how long he's had kidney disease, but maybe this is a little more involved than, what we were just talking about in terms of the bone.
So for bone pain, where is the bone pain? Which bones are involved? If you were on dialysis before, bone pain in a transplant patient, there could be some medical conditions that could lead to that. So I think it's really important to work with your transplant team. You probably should have your calcium, phosphorus, and your intact PTH blood tests checked to see about your mineral metabolism, if that could be a problem that's causing this bone pain. You could have, if you got exposed to steroids with your transplant, you could have bone softening or osteoporosis that could be problematic for you potentially. So I think all of those things should be addressed.
Okay.
But again, work with your transplant team.
I think this is something that most everyone would really like to get a handle on in terms of how NSAIDs actually affect the kidneys or harm the kidneys.
How do NSAIDs affect the kidneys? So NSAIDs affect the blood flow to the kidneys, and particularly the blood flow to the microscopic units we can see under the microscope that filter the kidney. So these microfilters are called glomeruli. There's about 1 million in each kidney, and the non-steroidal anti-inflammatory drugs affect something called prostaglandin metabolism, and that decreases the flow to these filtration units. Why that's important actually is kidney patients, people with CKD, especially if you take diuretics, and especially if you take drugs that we call ACE inhibitors, like lisinopril or Prinavil, they end in pril, or angiotensin receptor blockers, they end in sartan, like losartan or valsartan. These drugs also decrease the flow inside those filtration units, so that if you're taking those and you add the NSAIDs, that puts you at an even higher risk for sudden loss of kidney function or acute kidney injury with NSAIDs. Now those drugs, I should point out, are generally blood pressure control is kidney protective. The ACE inhibitors, the angiotensin receptor blockers are kidney protective, but the combination of the ACE and the ARB with the non-steroidal anti-inflammatory drug has been shown to be higher risk for acute kidney injury.
Let's see.
So we're looking forward to hearing your questions. Please submit your questions. And while we're waiting for a question, I'll just point out that if you or someone you care about is at risk, you think is at risk for narcotic abuse or narcotic dependence, we're going to be giving you a whole list of references at the end, but one resource is the National Council on Alcoholism and Drug Dependence. They have a Q&A that you can complete or have your friend or family member complete with yes and no questions, which will tell you if you're at risk for addiction. There is also Narcotics Anonymous is another source that can give you local resources for dealing with opiate addiction, and they also offer questionnaires to help you do a self-assessment or assess your friend or family member who may be at risk for chronic opiate abuse. I'll also point out that palliative care clinicians can help with pain, and now there are palliative care clinicians that are also kidney doctors in the United States, and there are several of them, and I was pleased to speak with some this week. They offer several websites that can be helpful to you. There's Get Palliative Care, which is called, it's getpalliativecare.org is the website. And then there is the Coalition for Supportive Care of Kidney Patients, and their website is kidneysupportivecare.org. So these are two organizations that can help you access or learn about palliative care in your area.
Okay, we have a good question coming in from John, who wants to know about contrast dyes, the nephrotoxicity of contrast dyes.
Okay, well, John, this has nothing to do with pain, but we'll talk about that anyway. Contrast dyes, the most important thing you should know, if you have decreased kidney function, you may be at risk for sudden loss of kidney function with contrast dye, and you should work with your clinician to limit the exposure or limit the risk of that if you have decreased kidney function. Procedures that are done angiographically, so procedures like coronary angiograms, where they look at the heart for blockages, which is probably one of the more common procedures where exposure to contrast dye occurs. That probably has a higher risk than IV contrast, which is given with CAT scans. There is also a type of contrast called gadolinium. These are gadolinium-based contrasts, and these are used with MRI procedures. And in general, if your GFR is less than 30, or you have we say 30% or less of kidney function, you should be careful about that. And most clinicians and radiology suites are aware of this risk, and that's another risk that you should also work with your ordering clinician to manage.
Okay, I have a question here from Corey, who wants to know if paresthesia in the groin has anything to do with advanced stage kidney failure.
Well, paresthesia sounds like it could be neuropathic, and that's something that you should have addressed with your clinician. If you've had a procedure in your groin, have you had a dialysis catheter perhaps that was inserted? Is there a surgical procedure that you had? Is there localized trauma that you could have led to that? Those are the kinds of things that would need to be addressed, and of course a physical exam would help determine if you have any sensory loss or change in your the way your nerves function in that region to help the clinicians determine what the cause is and how to address it.
Okay, I have another question from Kelly, who wants to know about topical cannabidiol oil to calm pain. So, it's a marijuana derivative that's used topically. Do you know anything about that?
Yes, so the question was about topical cannabidiol oil, and I don't really know anything about that, so I don't have any comments about that. That's not typically used for patients with chronic kidney disease, and that's something that we'll have to address, and if we find more information, we'll have to deal with that. And I would point out that Joshua Ryan, who is a nephrologist, wrote a nice article in the American Journal of Kidney Disease reviewing cannabinoids and chronic kidney disease in the February issue. So this is really tailored towards clinicians, but certainly that would be one resource. And I read that article, and I don't remember coming across that topic specifically. But certainly that's a good source for a recent review of the topic of cannabinoids and kidney disease.
Excellent. And Sean asks about if narcotics are the only thing that are helping with your pain, like what would be the process for, titrating and addressing opioid use in someone who has no other option to control their pain?
Well, I think that's something you have to work with your clinician, and I would also, the clinician typically will work with the CDC and their guidelines for how to monitor opiate use and how to help control the risks of the side effects and dose titrate. And there are a number of things that can be addressed to look for side effects, to treat side effects or prevent side effects from occurring. A bowel regimen, for example, to prevent constipation is one important aspect of that. And then dose titration probably would involve adjuvant therapy. So are there other therapies that may help him? Maybe they won't work on their own, alone if they're tried, but maybe if they're given together with the opiates, we can start to reduce the opiate dose. But all of these would require partnering with your clinician for monitoring.
Okay, James has a very good question about what type of medications are used to deal with pain and for comfort in palliative care.
Well, there are a lot of different medications, but of course, if the pain is severe, if the pain is from a terminal condition, then the opiate class are typically used. And I'm not going to get into the specific drugs that are used, but there are a whole list of drugs that are used by clinicians. For impaired kidney function, there are certain opiates that need to be avoided. Meperidine or Demerol is one of them that comes to mind that should be avoided, but typically those are used for pain control. But of course, there are a lot of other medications depending on what kind of symptoms the patient is experiencing. So if there's neuropathic pain, then the gabapentin, Neurontin, or pregabalin, or Lyrica that I mentioned before can be offered. Pruritus or itching, gabapentin is also often effective for pruritus. So really it would depend on the type of symptoms that the patient is experiencing. If there is shortness of breath, depending on the cause, there may be other medications, or there may be supplemental oxygen may be used to help manage that. So really I wouldn't narrow the focus of palliative care in a brief conversation like this. I would say that they address the whole patient and the symptom control in addition to pain. So they'll be able to address these other concerns like neuropathy, like itching, nausea and vomiting, constipation, insomnia, restless legs, all the symptoms that a patient may have at the end of life. And also, as I emphasized before, palliative care is not a prognosis. Palliative care is not only for people with terminal illness. Palliative care can be offered at any stage of kidney disease, at any level of kidney function, and in kidney transplant patients to offer symptom support.
Okay, I have another question from Sarah, which is very important. So she's been dealing with her pain by taking a lot of Tylenol and Excedrin. So maybe you'd want to give some information about that in terms of upper limits or what people should watch out for if they're staying away from, NSAIDs.
So Tylenol is generally safe at the recommended doses, but of course you can have chronic toxicity and generally liver toxicity from excessive use of Tylenol. So we would want to be careful about that. You would want to work with your clinician to adjust that dose appropriately. Even for patients with liver transplant, low dose of Tylenol or acetaminophen may be safe for you, but of course if you have a liver transplant, you'll have to work with your liver transplant team to make sure that's the case. Combining Tylenol with high doses of aspirin, of course, patients can have allergies to aspirin. Aspirin can cause gastrointestinal bleeding and gastrointestinal problems, so that I would be concerned about that combination with respect to the gastrointestinal side effects.
And we have another question about using low-dose aspirin in kidney disease. I know you touched on that, but just to emphasize about what's safe for people.
So aspirin is available over the counter, so you could do this on your own, but I think it's important not to take aspirin on your own, to work with your clinician to see if it's right for you. In general, depending on the indication, 81 milligrams or baby dose aspirin is recommended. There may be a higher dose in some cases. The adult dose, or 325 milligrams, may be recommended. There is good evidence that aspirin is beneficial in chronic kidney disease for secondary prevention. So if you already had a vascular event like a heart attack or a stroke, that aspirin has been shown to be beneficial, and it may be beneficial for primary prevention. So that's if you haven't had one of those events, but you're at increased risk. And I think it's important that people with chronic kidney disease know that there are many studies that have shown that you're at increased risk for cardiovascular disease when you have decreased kidney function and when you have higher levels of albumin or protein in the urine. So if you have one or both, you have increased risk of cardiovascular disease. And that's important because you want to not only consider aspirin therapy with your doctor, but also manage your risk factors, the blood pressure control, the diabetes control if you have it, and the lipid control if you have the dyslipidemia or elevated cholesterol. So visit kidney.org and we will answer remaining questions in the comments section. I want to thank you so much for your attention today. This has been a very engaging session, and we will also include our references for you, our other websites, in addition to kidney.org, for you to have access to. And thank you again.